Thank you. And it's a real privilege to be here. It's the second time I've had a chance to really, oh, I guess I need the microphone, right? Does it matter? Okay. So I'm going to talk to you a bit about pacing to prevent or treat heart failure, which is a subject that I've been involved in quite a bit over the past number of years. Here are my disclosures. So I titled this specifically Prevention and Treatment of Heart Failure because I think the way we pace the heart can actually affect it in both ways. So, and again, this is a short talk, so I really have to get through things pretty quickly. But when we talk about treatment of heart failure, we do know that patients who have class 3 or 4 heart failure, systolic, meaning an ejection fraction of 35% or less, and have dysynchrony benefit from it, and I will define that in just a minute. We also know that patients with lesser degrees of heart failure and dysynchrony can also benefit from the treatment. In terms of prevention, there's a couple of places where this comes in, and one is in patients with permanent atrial fibrillation who have AV junction or AV node ablation with LV dysfunction, who are paced physiologically and prophylactically to prevent heart failure. And then the last one, AV block in New York Heart Association class 1 to 3 and an EF of 50% or less. That's the Block HF study that I had the privilege of being the principal investigator on. So ventricular dysynchrony has a very specific definition. It can be electrical, in which case you have inter or intraventricular conduction delays. Usually it's manifested as left bundle branch block. Structurally, we see disruption of myocardial collagen matrix, and that impairs electrical conduction. And then there's mechanical problems with wall motion abnormalities, and we also get mitral regurgitation with it. And when one does cardiac resynchronization, and originally it was with biventricular pacing, the RV as well as the LV through the coronary sinus, it's the therapeutic intent of biventricular pacing, and you can see often the QRS narrows, but that's not been shown to be obligatory in terms of the impact that you get. This kind of pacing therapy is complementary to optimal medical therapy. So there's a number of proposed mechanisms for how cardiac resynchronization therapy works. It can resynchronize intraventricular conduction as well as interventricular synchronization. AV synchrony is improved as well, and there are a number of other hemodynamic and physiologic benefits that are all laid out here. Pulse pressure, cardiac output, ejection fraction, etc., all improve, and the result is reverse remodeling. There have been many, many studies done on this topic, and the original studies, most of which are the ones that are here, talk more about the actual impact on cardiac structure and function and some very important outcomes for patients. So you can see universally LV ejection fraction improves in patients, mitral regurgitation tends to get better, and there are a number of other hard endpoints that people have looked at to show that the technique improves outcomes. Cardiac resynchronization therapy also improves the quality of life score and New York Heart Association functional class, and you can see that for every study in which it's been measured, there is a positive impact on it. So where does that get us? And again, for the sake of time, this is one summary. It's from 2013, but it's still actually quite relevant. So if you're looking at patients who have been on guideline-directed medical therapy for at least 3 months, you have to get at least 40 days away from a myocardial infarction, and or they're getting it paced or having a defibrillator implanted for special indications. The way the flow diagram works is, let's see here. Yeah. So I would concentrate down here. And so if you look at the New York Heart Association clinical status, and if patients are class 2 or class 3, New York Heart Association, and ambulatory class 4, if they have an ejection fraction of 35% or less, a QRS duration of at least 150 milliseconds, and a left bundle branch block pattern and sinus rhythm, that is a class 1 indication. And so really, if your patient fits that category and does not get a cardiac resynchronization device, they're likely not going to have the best outcomes. So those are class 1, very strong evidence for them. Then when we get into the 2As, where the weight of evidence is in favor of doing this therapy, the qualifiers here are if the QRS duration is less than 150 milliseconds, but still left bundle branch block with a QRS duration of more than 120, or you have a non-left bundle branch block pattern and the QRS is very long. So there's some qualifiers in there. And then the more narrow the QRS, the non-left bundle branch block pattern, and ultimately you can get to situations where there really isn't any benefit. One of the qualifiers I would have here is that women do have narrower QRS durations naturally. And so when patients have a prolonged QRS duration, for women it tends to be relatively longer from normal compared to men, and that's actually one of the reasons why women have benefited more from CRT. These are from the European guidelines. They do mention some of the same factors, and you can see level of evidence A means multiple randomized clinical trials, and class 1 really does mean the patient should get the therapy if at all possible. So symptomatic heart failure, sinus rhythm, prolonged QRS duration, left bundle branch block morphology, and a low ejection fraction despite optimal medical therapy. I might add that I've been part of a group with the major cardiac resynchronization clinical trials where we've pulled the data to be able to make observations that you couldn't make without it. And what we have found is usually we've categorized left bundle branch block and then IVCD and right bundle branch block. And it appears that the right way to categorize would be to take IVCD, interventricular conduction delays, and put them in with left bundle branch block because those patients do tend to benefit, whereas patients with pure right bundle branch block do not. That paper just got accepted for publication, and it'll be coming out in the coming months. So, so it's a different way to look at it and something worth knowing about. And I'm sure it will impact the guidelines eventually. And I won't go through these because it's essentially what I did show you. When patients have heart failure, it doesn't matter what the Heart Association class is, and they have high-grade AV block, you really should start with cardiac resynchronization therapy rather than RV pacing because you will see better results with that. And there are some other categories as well that I won't go through for the sake of time. For patients who have permanent atrial fibrillation and they have heart failure, a YQRS, and a reduced ejection fraction, one should consider doing cardiac resynchronization therapy. But the caveat here is that if you put these in these patients, you need to get 100% ventricular pacing, biventricular pacing, or as close to that as you can get. When patients have below 90% ventricular pacing, and the native conduction system comes through, the results are worse. And so commonly electrophysiologists will ablate the AV node in these situations, which guarantees 100% biventricular pacing. And this is how the flow diagram from the European Society of Cardiology. And again, looking at whether there's heart failure or not. If you have a reduced ejection fraction and a tachycardia-induced cardiomyopathy or uncontrollable heart rate, then AV junction ablation makes a lot of sense. If the QRS is narrow and you can get adequate rate control, then you really shouldn't be pacing the patient. So there are indications here for using cardiac resynchronization therapy in patients with AFib. And in my experience, when you pick the patients correctly, they do have a dramatic benefit. Sometimes we have to upgrade patients from conventional pacemakers or ICDs because they have a high percentage of ventricular pacing and they're in heart failure despite medical therapy. And then for de novo implantations, I believe that patients should be considered if you expect that there will be a high percentage of ventricular pacing. The Heart Rhythm Society has guidelines on cardiac physiologic pacing that are coming out. I was on that writing group. We're getting to the finalized part of that. It's going to be published. The big question always comes up is what's a high percentage of ventricular pacing? And nobody knows. And so basically we have to hedge because if you don't have firm data, it's hard to say. But Just definitely somebody over 40% I would put in that category. What happens when you're 20 to 40%? That's going to be clinical judgment. I want to mention a couple of alternatives, though, to biventricular pacing before I finish, because there are a couple of exciting developments here. And it was specifically because of these new techniques that the Heart Rhythm Society did decide that they needed a physiologic pacing guideline. So the two alternatives to biventricular pacing are His bundle pacing and left bundle branch area pacing. This is an example of selective His bundle pacing, and it's really cool because what you can do is you actually screw a lead into the His bundle itself, and if you get it correctly, you'll have that slight delay before the QRS that reflects the HV interval. You get a narrow QRS, completely like normal conduction, and it's a very good way to resynchronize the patient, except it's not easy to do. So, and why would it even work in somebody with left bundle branch block? Well, the suggested mechanism is that you can have longitudinal dissociation in the His bundle or in the Purkinje, the bundle branches, and then by putting in the lead in the His bundle area, you can get resynchronization there. So it's a technique that does work. It's a very flimsy lead. It's a 4 French lead that has no lumen in it, and so you have to put it in through a specially designed sheath to point at the His bundle, and then you have to rotate the lead to screw it in. So it's not simple. So what are the results that we've seen with that? Here's one study of permanent His bundle pacing as an alternative to biventricular pacing for resynchronization therapy. So this was done as a rescue strategy for patients with failed LV lead implantations or non-response. If you can't get the LV lead into an optimal position, you're not going to get the results you want with cardiac resynchronization therapy. So in this study, and these tend to be people who are pretty experienced, they had success in 90% of the patients. They did get a nice increase in LV ejection fraction from 30 to 43%, and New York Heart Association class improved by 1 class. But there are challenges with this technique. There's a steep learning curve with it. It's technically difficult in some patients. You will have lower success rates in patients with QRS prolongation, and another factor is high unstable pacing thresholds. We also don't know what happens when a patient's had a lead like this for 5, 10, 20 years because nobody's had them in that long. So frankly, despite the fact that we've had data on this for quite some time, I've seen very few electrophysiologists picking this up as a routine way of pacing patients. Which brings me to left bundle branch area pacing. Similar technique, you're pointing at the septum, and you have to engage the left bundle branch so that you have to screw the lead into the septum almost towards the left side. But you're not going to get as narrow or QRS, but there are some real advantages to this approach. I will qualify, this doesn't mean you just throw a lead in the septum. You've got to get it by the conduction system. But if you do, it's easier, the thresholds are lower, and I think it's a pretty exciting approach. Dr. Vijay Rayaman, I'm sure I just butchered his name, has been a leader in publishing in this area. So he looked at left bundle branch area pacing for CRT. This is one large study, although it's not a direct comparison to other approaches. 325 patients with low ejection fractions and indications for CRT or pacing. Here, 85% success, and again, I think that's early on in anyone's experience with this particular technique. QRS at baseline was either left bundle branch block, non-left bundle branch block, and others. Good pacing thresholds and R waves. LV ejection fraction, again, improved from 33 to 44%, and he showed that this approach is feasible and safe. We now, you can see this is 2022, are starting to get randomized trials looking at left bundle branch versus biventricular pacing for cardiac resynchronization therapy. So this was a prospective trial, only 40 patients, so you consider it really more of a pilot study. Crossovers were allowed if the initial approach was unsuccessful. Their primary endpoint was LV ejection fraction at 6 months, and they found that with left bundle branch area pacing, they got a higher or better improvement in LVEF, 5.6%, it was higher by 5.6% compared to biventricular pacing. So that doesn't say anything about heart failure, hospitalization, survival, and the rest, but it does show that EF goes up, and normally when that does, you will have better outcomes. So what are the implications of doing this approach to resynchronization therapy? You can get a pacing site distal to the block in the conduction system, which is how it can resynchronize. It's an easier technique to perform than His bundle pacing. You get lower and more stable pacing thresholds compared to His bundle pacings, better R-wave amplitudes, and it is an alternative to conventional CRT. So we're still looking at what the optimal pacing sites are, QRS durations, and morphology for doing this, as well as pacing mode and parameters. They're all under active investigation now. So finally, long-term outcomes are not yet known with this technique, but we will learn those in the coming years. So in conclusion, cardiac resynchronization therapy is beneficial in many patients with heart failure and or AV block. I've shown you the kinds of patients who can improve with this. And patients even with mild heart failure and more advanced heart failure can improve. Don't forget patients with permanent AFib and LV dysfunction who might benefit from AV junction ablation. And then we do have these alternative approaches of His bundle pacing and left bundle branch area pacing that are under active investigation. Thank you.